My name is Diras Jalori, and I'm a Master Public Health student and the Director of Conference for Anderson's Healthcare Business Association. I arranged this panel so that healthcare professionals could share their perspectives on patients' current struggles and our new healthcare environment, especially through the lens of mental health and equity. I'm honored to now introduce our panel's moderator, Dr. Kristen Choi, who is a psychiatric nurse and an assistant professor of nursing and public health at UCLA. Thank you.
Thank you so much, Jiraj, for organizing this great panel today. And hi, everyone. I'm really excited to be here with this amazing group of panelists to get to moderate our discussion. The focus of this panel, of course, is mental health and equity. And as we all know, these issues have become a huge problem in our current healthcare system during the COVID-19 pandemic. But also, before the pandemic, they were problems. So really looking forward to hearing what our panelists have to say. Today, we're going to do some moderated questions with the whole panel, and then we'll take questions from the audience as well, and would love to hear your thoughts and your questions for our panelists about these topics. Before we start, I'd like the panelists to briefly go around and introduce themselves, just so you all have an idea of who is here. And of course, we'll get to hear much more about what you all do during our questions. But to start, for introductions, could I ask Dr. Gustavo, if you could kick us off, please, and just let us know your role, your organization, and some of your expertise.
Yes, thank you. Good afternoon, everyone. My name is Gustavo Loera. I am a researcher and educator or in the area of mental health with a number of organizations and academic institutions. One of my several leadership roles is serving as a board member for NAMI California, or the National Alliance for Mental Illness. It was my good friend and colleague, Jessica Cruz, the CEO of NAMI, that I was invited to be a part of this panel. For the past 20 years, my research and work has centered on children and youth mental wellness and developing school-based mental health programs, specifically focusing on early identification, prevention, and early intervention, with the goal of ultimately looking at children who have been exposed to risk factors and to work on solutions that change their life trajectories from mental illness to wellness. And so my hope is to share as part of this panel, some of the work that we've done in regards to mental wellness in schools and children and their families. And I'm looking forward to this, again, very important and timely conversation. Thank you.
Thank you. Next, can we go to Dr. Kuo?
Sure. Hi, everyone. I'm Dr. Tony Kuo. I am a family physician by training, and I currently direct the Division of Chronic Disease and Injury Prevention for the LA County Department of Public Health. And I also work as a professor over at the UCLA Fielding School of Public Health and David Geffen School of Medicine. A bulk of my work is actually in policy and systems level change, and have traditionally, or at least in recent years, been working a lot with how to scale team cares approaches, and also to look at social determinants of health type issues such as food insecurity and to some extent some of the related housing issues as well.
Thank you so much. Next, let's go to Dr. Casillas.
Hey everyone, thank you for having me today. I'm Jacky Casillas and I'm a professor of pediatrics at UCLA. I've been here for 20 years. Clinically, I'm a pediatric oncologist and I focus on teen and young adults diagnosed with cancer. Research-wise, I'm an alumni of UCLA, so shout out to all our public health attendees. And I'm a health services researcher that focuses on adolescent and young adult quality of life and quality of care in cancer survivorship, with a focus on diverse communities and looking at basically interventions such as text messaging to try to improve access to care.
Great, thank you so much. And last but not least, Dr. Lamp.
Hi, everybody. My name is Dr. Karen Lamp. I'm a family medicine physician and the Associate Medical Director with the Venice Family Clinic. The Venice Family Clinic is a federally qualified health center We provide services to 27,000 low-income patients. About 15% of them are experiencing homelessness. So we not only provide primary care services, but also have behavioral health services in the form of licensed clinical social workers, a psychiatrist, and then a very wide range of services, which tend to be fairly comprehensive to meet a lot of the needs of our patients.
Awesome. Thank you. So to start off with some of our moderated questions, the first question I have is, what new struggles, especially regarding mental health, do you find that patients are facing right now? And I'd like to ask, if it's okay, Dr. Kuo, if maybe you could start off our conversation on that question.
Well, sure. I think, in face of the COVID pandemic, I think one of the things that, since it's gone so long, the issue around more trying to, people who are depressed, social isolation, and quite frankly, this actually also go to the issue of equity, because there are some population that the social isolation is even more of a problem. That certainly have come to light, I think, for many of us who actually are working in the healthcare and even in the public health arena. The other area that I probably wanted to point out is that there's also this there's also the digital divide that actually has popped up. As you know, because of the pandemic, a lot of services actually have gone virtually, especially in primary care. And while that in some ways it helps streamline some of the services and use of technology and telemedicine that we've never had to do, in other ways, it actually has created a lot of struggles, I think, for a number of patients, especially those who actually do not have access to good internet, who struggles with the technology of actually using video cameras and even some of these things that we take for granted right now with the Zoom platform.
Well, thank you so much for that. Would any other panelists like to comment on this question?
I mean, we're seeing tremendous prevalence of what Dr. Kuo mentioned: depression, anxiety, social isolation, and really kind of overwhelming levels of grief. We serve a lot of Latino families, and many of them live in multi-generational homes and many are essential workers or non-essential workers who are still working and were unable to isolate when necessary. So I think we all know the numbers of infections in that community, and it's so different than what I'm used to treating in primary care, because primary care physicians do treat a lot of depression, but this is not a situation that you can just write a prescription for an antidepressant. So we're really trying to provide supportive services to our families. But another population I wanted to mention that has been hard hit is those dealing with substance use issues. We actually have a pretty robust program for people with opiate dependence, but it's been really hard to maintain those linkages with that population. And unfortunately, we've seen pretty significant increase in drug overdoses related to that. So I think the whole issue of social isolation has really created really terrible outcomes in people struggling with those issues as well.
Thank you, Dr. Lamp.
Yeah.
And yeah, Dr. Laura, did you have a comment on this one as well?
I think that job burnout is something we should be concerned about. On an individual level, I think that for healthcare providers, the personal safety, self-care, and also the mental wellness, I think is being in many ways threatened, in the sense that there's, the trauma that they're experiencing by seeing so much suffering, and in many cases, even people dying, I think is really taking a toll. And so I think that we talked about isolation and loneliness. We're also seeing that happening in our healthcare providers, not just in the healthcare industry, but in the mental health industry, but also undetected depression. There's a professional stigma that we just don't talk about, especially if you're in that profession. And we think back to April, we can remember the story of Dr. Lorna Green, who was an ER physician in New York, who died by suicide because the sense of hopelessness and helplessness and this feeling of being alone. I think it's something that is putting our providers at greater risk. And then from the industry perspective, I think that if we don't address the job burnout, we are going to have a serious job workforce shortage, post-COVID. And so I think it's something for us to really think about is how are we making sure that our providers are receiving the kind of service or the kind of help and support that they need during the pandemic.
Thank you for making that point too, Dr. Laura, about the issues with the provider workforce when it comes to mental health. Before we even move on to Dr. Casillas, I was wondering too if you might want to comment on this question about new struggles in mental health that might be facing kids. I know you mentioned that you have some expertise in mental health for kids, and would love to get your thoughts too on how we see this playing out for our kids and teens.
Yes, trauma is going to be a huge struggle for young people, and even talking to teachers, they are aware that their priority will be the mental wellness of their students, even before teaching. And one of the things that we're seeing happening is that a lot of our young individuals are being exposed to violence. Obviously, domestic violence has become something that we've seen rise, and with that, obviously comes child abuse. And so I think for students to not be in school that was perceived as a safe space for them to interact with their peers, to interact with their teachers, is really, I think, putting them at greater risk of future mental health issues. And again, the sense of being isolated, feeling lonely is also a major issue that we're seeing with students. Now, the other part that I think is problematic is that for youth who want to seek help, but do not want to tell their parents, is very difficult when they live in a household with many people that they're not able to talk about or even ask for help because of their parents or someone else listening in on that conversation. So there is a lot of concern when it comes to youth, and again, when schools reopen, I think that there's a lot of concern that students may come with way too much trauma. We already know that the onset of 75% of the adult mental health issues are by age 24, but 50% are by age 14, with symptoms coming in 5 to 6 years earlier. So again, we're talking about kids at the elementary level who may already be experiencing some of these risk factors that something we kind of see as stress, but don't see it as being associated with mental health issues. If we don't do early identification in schools when kids return, we might miss an opportunity to identify someone who may be already headed in or be on a course to a mental health issue, and for us to be able to get them the support that they need to avoid them.
Great. Thank you so much for sharing that perspective, Dr. Laura. And Dr. Casillas, did you have a comment too in this question? New struggles related to mental health that you're seeing patients facing now?
Yeah, just building upon this discussion on the impact of children and adolescents. Our UCLA program recently, in the last 5 years, now serves a large community within Memorial Health in Long Beach at Miller Children's, and we're a very large community hospital that serves children with complex healthcare needs. And what we've been seeing, on the front lines is our children who are going through, for us in oncology, life-threatening treatment or other life-threatening blood disorders. They're seeing many times when a child gets sick, for us in oncology in particular, because of the intensity of medical treatment, repeated hospitalizations, frequent clinic visits, need to isolate even outside of COVID with their immunocompromised status, one parent will not work because they have to be that primary caregiver, and then they have the other parent who's working. And what we've been seeing is that parents are dying of COVID, and we know that we have higher rates. It's been discussed nationally, like in our community of Linwood up to 710, that, the death rate is 1 in 400 persons who are going to die of COVID. And then if you compare that to Brentwood, which is where UCLA sits, it's 1 in 3,000. So our children have had tremendous amounts of stress, not only from having complex medical conditions, but on the impact that the parents risk and their illness that they're facing, having family members die, having parents die, and then trying to figure out the financial toxicity of all of this healthcare that they're facing because of complex pediatric cancer diagnoses. So it's, even going through cancer treatment as a young person, it has like a post-traumatic stress model many times. It's even greater in this current crisis because there is so much, like's been discussed with the panel, with food insecurity, housing, and then with the higher death rates or hospitalizations of parents getting ill in the context of COVID.
Thank you for bringing in that perspective too, that it's not just the pandemic stressors. There's also the stressors of having chronic illness and other things that were going on for people pre-pandemic. So that's very helpful perspective. Thank you. The next question that I have for the panel, and if it's okay, I'd like to ask Dr. Lamp to kick us off on this one. Can you discuss how equity issues have compounded in light of kind of the new struggles patients are facing and the conditions of the pandemic?
So I'm largely speaking from a perspective of access to primary care. And I was thinking about this a little bit, and all I can say is thank goodness for the Affordable Care Act, because that really moved, for our patient population, historically 75% of them were uninsured. And 10 years ago, when the Affordable Care Act passed, that ratio flipped. 75% of our patients are now insured. So I was just really grateful at this terrible time where people needed access in one form or another, whether it's telephonic or in person, that our patients largely continue to have access. I mean, I kind of have to give a shout out to community health centers, because this is really our mission in life, is to reduce those inequalities that you see and provide the best care possible. And maybe a sort of a resource restricted environment, but to really kind of reduce some of those health inequities. I do think a lot of people, who lost their jobs, had never been covered by public insurance before, had to struggle with a new bureaucracy and figure out that sort of how to access care when you have Medicaid or Medi-Cal coverage. So, just if anything, it just exacerbated the whole situation. And I think, I guess a good thing is that I think it really brought a light was shined upon this issue, and people are talking about it. And we're certainly seeing it in a big way when we're talking about the vaccine rollout and who has access to the vaccine and who's getting it. But fortunately, it's getting a lot of press, and I think some of the powers that be are trying to make some efforts to make sure there's better equity involved with that.
Thank you, Dr. Lamp. That's very helpful. And I think bringing to light the issue that even though we have the Affordable Care Act, it hasn't fully resolved all of the access issues, and some of them may have gotten worse, in recent months.
Right.
Would any other panelists like to comment on this question? Yeah, Dr. Casillas.
Yeah, I think a couple things that come to mind, as was brought up earlier, is the issue with the digital divide. So many times in this pandemic, we are moving towards telemedicine for those patients to try to decrease patient numbers in the clinic, but still being able to provide those outpatient visits. But many times, I will say, within the community that we serve, through Long Beach and our greater surrounding communities, many times it's very difficult, even though we have an electronic medical record, which is how a patient would have to log in to have a HIPAA protected platform to give that telemedicine visit, it's very challenging for many of our families to want to go onto an electronic medical record, have access. There's often language barriers because we serve like a very diverse community, and with many different languages that our families speak, we might use a what we call a VIC translator, a video assisted translator, and we don't have those same services available, for example, on the telemedicine visit. The second thing is also having equitable access to the mental health care support. So within our children who have complex mental health care needs for their chronic illnesses, we do have philanthropically, supported programs to help them through, particularly in oncology, with the anxiety, depression, and the different mental health issues they may face because of the illness. But it's even been greater, and being able to have family therapy in languages that all families can participate in has been another equity issue for us, to be able to have multilingual providers of care. But it also has doubled, like many of our psychology follow-up is now through telemedicine, but there's many challenges, like I said, to be able to use the phone, get on that visit, have the language be appropriate for the family. And so I think those two things, the digital divide with telehealth, as well as the access to mental health care services that is culturally appropriate and with languages so everyone can benefit, are challenges that, I think continue to increase as we are doing complex illness and the pandemic.
Great. Thank you so much for those comments, Dr. Casillas. Very helpful. Well, let me keep going through our questions. And of course, if other panelists want to chime in on that question of equity as we move forward, that would be great. The third question I have is, what advice would you give to managers and administrators in healthcare industry or provider settings? You all are kind of coming from the vantage point on the ground of being clinicians or people that are working closely with patients. What advice would you give to people who might be in healthcare leadership or wanting to go into healthcare leadership from your vantage point? And maybe we could have Dr. Laura, if you could kick us off on that question.
Sure. One of the I guess principles of community engagement is that before COVID-19, you would go into a community. There's a level of mistrust that people have in going into whatever they perceive to be government agencies, and so oftentimes. We look at ways of engaging the community. We go to where they live, where they study, where they work, and try to provide services. And I think oftentimes we miss the opportunity of using community health workers or promotoras, as we call them. These are trusted individuals that are well-rooted in the community, who oftentimes become the best messengers with regards to minimizing stigma or reducing stigma. And I think one of the issues with COVID is obviously we can't have, there's that part of being in the community has been limited to a great extent. But I think oftentimes one advice would be to ensure that that these conversations, these dialogues in the community happen through these community health workers in order to build that trust. Because I think once we move beyond COVID, that mistrust will probably be greater. We're seeing that now with the mistrust in vaccinations, because the message is not culturally or linguistically appropriate to the communities. And so I think, again, looking at who are these community champions, these community brokers or cultural brokers that can help us better connect with the hardest to reach, most vulnerable communities that were already marginalized before COVID, and now we're expecting to see more of that marginalization with working with communities. And I also want to say that another community that I think we oftentimes don't talk a lot about is the LGBTQ community. That we have to find better ways of engaging the LGBTQ community to find solutions that best work for their community. And again, more on talking about the engagement of those communities to find the right solutions to some of these health and mental health issues.
Thank you so much, Dr. Laura. Any other panelists want to comment on this question of advice that you might give to healthcare leaders and people in the healthcare industry?
Yeah, this is Dr. Kuo. Not necessarily advice, but just an observation. One of the things the pandemic really has taught us is how important, and for some reason this gets overlooked a little bit in terms of how we're delivering services right now, is the fact that chronic disease, this is from a chronic disease perspective, the concurrent chronic conditions is apparently having it under control apparently is quite important, since COVID has actually hit many of the common chronic diseases like heart disease and hypertension, and in some way even mental health pretty hard. And I think one thing in terms of moving forward as you think about healthcare services redesign or structure, or as we get out of the pandemic, is understanding or moving towards a better infrastructure where we could actually get that under control a little better.
Great, thank you for making that point, Dr. Kuo. It's very helpful.
So I can speak a little bit about our approach at the clinic with the onset of the pandemic, kind of speaking at it from a different perspective, but I mean, we realized we had to do things differently very quickly, and we put together an emergency response team, which I'd never participated in before. And I think initially we met, it was like some senior managers, clinic leadership, and we met almost every day. And what we learned very quickly is that we all learned to be very, very flexible, because you would make one decision one day and a new protocol would come out the next, and you really have to. We use the word pivot a lot. We had to learn to pivot a lot. So that required a lot of flexibility amongst our team, and then really good, effective communication throughout the organization, because you can't make decisions in isolation and then expect people to implement those things. So communication was really key. And then really having to be very sensitive to where people are at and being very, compassionate. We had a lot of staff with young kids who couldn't come into work. The kids were home from school, a lot of illness, that sort of thing. So being flexible in how what you expect of your workforce, and also being sensitive to the stressors that they're dealing with, and even allowing some sort of a venue for them to talk about those things. Yeah, so flexibility, communication, sensitivity, I think were really, really key. And of course, one thing that was really important is creating a safe work environment for both our patients and our staff. And I think we were successful in that, in terms of having, as far as we know, no work-related infections. People unfortunately were getting sick at home, but I think most of our staff felt pretty comfortable coming into work. But there was a lot, there were so many crazy mask guidelines and this and that. Things were changing constantly. And, initially we didn't even know if we'd have masks, right? We forget, that was a year ago, but things happened pretty quickly.
Yeah, thank you so much for that perspective, Dr. Lamp. And actually, that's a perfect transition into our last moderated question that I'm hoping Dr. Casillas can continue kind of this discussion. So we talked earlier about the issues that patients are facing kind of right now in COVID and in regards to mental health. And Dr. Casillas, I'm wondering if you could talk to us about what new struggles providers are facing in healthcare related to care provision in regards to mental health and equity, or also their own mental health.
Yes, it's been highlighted in the panel that there is this burnout. So for the providers, similar to what the panelists have been saying, we've had to have a lot of flexibility with our workforce, because if we have young children at home and then they're still expected to, come in, and how do we manage workplace shortage issues? our providers, nurses, social workers, doctors, psychologists, they all want to be there and they want to serve, but there is that fatigue that we see just because of the all of the changes, like it was being highlighted, that are happening on a daily basis about, whether it's a visitation policy or the fear of getting COVID, kind of highlighting that comment about not having masks. When this first started, there was so much confusion about these different guidelines that kept changing so quickly with our providers. And one of my doctors who had a chronic medical illness, she started wearing a mask. It wasn't recommended, but she was so fearful of getting COVID. And then within the hospital setting, I got from different administrators, can you please talk to your doctor? And she's scaring everybody wearing the mask, and we don't want to scare people, but the fear is real. And then, it went on to, I had to say I can't disclose, but because of people's own medical health issues, they can make certain choices. So there is this, with the rapidly changing recommendations, many times that stress that provides stress. I will say that we've talked about even recently in the context of the storms, that for us getting certain chemotherapy, that standard chemo that's delivered to the pharmacy, that they may not be able to deliver it in a timely fashion because of all of the weather issues that we're having, and the stress that puts on providers about how can we not give the care to the children, how can we not get these medications. And then I think in the context of having resources for the providers on a daily basis about what can we do in the workplace to support them. There are deaths or children can get very sick. And for example, things that can be put into place, I think, by managers and administrators is and I'm sure it's at other hospitals, but we do Tea for the Soul, where it's just kind of a debriefing at 7:30 for those that were on the night shift and had a very difficult inpatient shift, and then we do another one in the evening for those who are finishing their shift, just to have a place that's open to support them, involving the spiritual care resources that you may have, or social workers or psychologists, to also support the healthcare providers that are equally as stressed, dealing with the same childcare issues, ill family members, possibly chronic illness of their own, in the context of still being I don't like the term caregiver burden, but the day in, day out of providing that care, and what we can do both in the workplace as well as flexibility with the work schedule to allow them to have the self-care to kind of keep going.
Great. Thank you so much for that. And would anyone else want to comment on this question of challenges that providers might be facing? We already heard from a couple folks on this. Dr. Laura, you had some great comments on this, and Dr. Lamp, you did as well.
I mean, it's an interesting dynamic that when you wake up in the morning and you realize when you're going in to see patients, are you going to get sick because of that? That isn't, and I've been practicing medicine a long time, that isn't something I used to wake up thinking. So it did create a different dynamic, right, in the doctor-patient relationship, and how much time you want to spend with the patient. And having gotten the vaccine has changed all that tremendously. Like, I think we all have this tremendous sense of relief for now. I mean, we're a little concerned about the variants, but that's just your own sense of personal safety. That was a really new dynamic. Kind of took me back to the days in the early 80s with AIDS, when we didn't understand how that was transmitted, sort of similar feelings, but this clearly had its own, it really had a big impact, I think, on healthcare workers' experiences.
This is Dr. Kuo, and I kind of echo that. I know many that recently work on a search, fortunately the vaccine started to come out, but before that, you see traditionally a lot of physician and healthcare providers, they don't really tend to themselves. And you kind of saw that in the pandemic too, where people are working very hard. And of course, they've seen colleagues who came down with COVID-19, and then some of them actually even passed away from it. And that, I think there's certainly trauma there that's not often spoken of, or the providers themselves don't actually seek help when they probably should.
Thank you for that, Dr. Kuo. We appreciate your comments there. Well, with that, I want to change gears to asking some questions coming in from the audience. We have some great questions here and would love to continue our discussion and get thoughts from the group on some topics that are of interest to our audience here. And for these, anyone on the panel can respond. I'll start with this question about the role of therapists. The question is, what do you see as the role of licensed marriage and family therapists and licensed professional clinical counselors, so various kinds of therapists who might not be physicians, in your healthcare delivery systems? And how could they help with the mental health workforce shortage that we know is out there?
I can speak to what we have at the Venice Family Clinic, which is very much an integrated model and works really great. We have licensed clinical social workers who we work with, but I think they provide the same level of service. So anytime I'm either with a patient or talking to a patient on the phone, if I identify some kind of a psychosocial issue that requires more time and expertise than I have, I can connect them right away. We always have somebody on call who can either call them back or see them in person, and they do kind of a deeper dive on what the issues are. And sometimes there are issues I have no idea, didn't come up at all at the time of the appointment. And either we can provide them with short-term therapy, or we can refer them out for longer-term therapy. And then sometimes the therapists also have a good sense of whether they think that person might benefit from medication as well, depending on the severity of the symptoms. So it's a very collaborative relationship, and then they loop back with us so we know that what's going on with that patient. So I think an integrated model is really ideal. You capture the patient when they're there at the time they need those services. So it in a setting like, I think it's a little unique compared to maybe a private practice setting, but certainly in the community health center setting, this is very commonplace.
Another area that I work with a couple colleagues that are have an MFT background, and one of the things that they're doing is through this strategy of called mindfulness, and what they're doing with schools is that they're actually training young individuals on how to use mindfulness as a strategy to deal with stress, but also while they're doing that, they're also introducing students into a career path in mental behavioral health. Oftentimes, students don't realize that because of their lived experiences and because of what background they come from, that they have the capacity, the protective factors that they are exposed to from within their community, their culture, and through mindfulness, they realize that they can be future social workers, MFTs, but I think part of it is, how do you reach the schools? How do you incorporate strategies like mindfulness in the curriculum, so students begin to not only learn how to use it, but how they themselves can be on a career path towards again to fulfill the mental health shortages, workforce shortages that we see in the future.
Thank you both so much for your answers on that. The next question that I have from our audience is that you all here on the panel are accomplished members of the provider space and academia and public health. Again, you are people who are on the ground and doing this work with patients. And from your vantage point, how would you want to interface with the business community? What kind of strategies or mindsets should people from the business space bring to the clinical space that are important for collaboration to leverage what we know about science, clinical knowledge, as well as innovation? Tough question. Anyone wanna start us off on that one?
Yeah, hi. This is, maybe I could attempt to tackle that. I think it's a broader. This is a broader communications issue, and also just like stakeholder engagement. But I think business communities can add a lot, because if you think about it, even in this whole pandemic, it really is the private sector with the pharma that actually came out with the vaccine. So I think being able to partner. A public-private partnership is always important. I also think that moving forward, because pandemics like COVID-19 is probably here to stay, and we may have other pandemics in the future. And I think even as we start to inch out of COVID-19, this pandemic, it's probably a good idea for both public health and the health system to probably have stronger ties with business communities, which could in the future be, quite frankly, the first defense against future sort of health crisis and health emergency, in that they could do a lot to prevent both infection, transmission, and even just educating employees and the public.
Thank you, Dr. Kuo, for that response. And Dr. Casillas, did you have some thoughts to add?
Yeah, I think that, like was highlighted in the private business community, I think things move a lot quicker than in academics. And, I've been at UCLA for over 20 years. And one of the things, like in this pandemic, like as an example, is looking for opportunities where there could be either philanthropic or specific type of grants to take things that might be known clinically or scientifically and trying to develop it to reach a larger community. So, for example, there are, these small business grants that in my area, in the National Cancer Institute offers. In my research on the academic side, like I said, focused on cancer survivorship, we were trying to say, what could we do to educate our patients about the need for survivorship care, because they can get very ill for various reasons. So with a traditional NCI grant, I developed something called a fotonovela, or a talking picture book, to educate, and the intervention proved to be effective. But having something, to give out in clinic, whether it's a paper format, that's only going to go so far. So during the pandemic, there was an opportunity of another business that did technology, and I've done some text messaging, and they say, we have this innovation. Could we partner that with what you did on the research side and submit a grant? And then that way, it was a really good working relationship. You do have to learn, because like UCLA being a big academic institution, there are certain things you do to submit a grant, but there was flexibility on the business side to kind of meet those requirements and still kind of keep the deadlines, being met. So I think if there's opportunities, whether it's philanthropic or, through the example of the NCI, of how there could be grant partnerships so that you can get additional funding, and then being able to leverage what business communities can do much quicker than an academic community may do, but, kind of maybe saying something that was developed on the academic side to partner with the business to be able to move it forward quickly. I think those are ideas that, we think is particularly exciting, on the academic side, if there's business communities to be able to partner.
Great. Thank you so much for that. So then the next question I have from our audience is about disparities in quality of mental health care. The question is, do you think that there is a disparity in the quality of mental health care received? And if so, what efforts do you think there should be to monitor and improve quality, similar to what we've seen happen on the medical side of things with things like HEDIS measures and such? How could we improve quality of care if there is indeed a disparity and an issue there? Anyone like to start us off on that one? Dr. Laura, I'm wondering if maybe you would want to start us off just from your vantage point with NAMI and kind of on the ground and mental health.
Sure. One of the things that I think that happened in California was the passage of the Mental Health Services Act in 2005. And part of that was to identify some of the most vulnerable communities that have historically not had access to mental health services. and one of the things I think that has happened is that we need to recognize that most vulnerable communities that have, or at least do not view mental health as something that you get treated for. That oftentimes, again, they don't come for help to a clinic or an agency. Part of it is that there's a number of disparities that they experience. One, of course, is transportation. Obviously, not having insurance is another big issue. And so part of what we're doing with several counties is how do we engage the community as part of the solution to identify strategies and solutions that work best for them. There is no kind of a cookie cutter or one size fits all. And part of it is also how do we look at cultural and linguistic appropriate services. One example in which we're doing with one county is applying the class standards, the cultural and linguistic appropriate services standards that are nationally recognized as a way to train and retrain providers on how to appropriately reach out to communities. The other part, I think, is the contextual aspect or the context in which services are provided. Oftentimes, we have to look at how our lived experiences, or how do we leverage off of lived experiences in regards to making those connections with communities. So there is a lot of, I think, definitely stressors. Stress is these social determinants of health that I think keep people from seeking services. But also there's a utilization of services. Oftentimes, particularly communities that do not see mental health as an issue, if they do seek help and that experience is not favorable, the likelihood of them returning is very minimal. And so, again, there's a number of I think, elements that keep people from seeking services. And one of it is, of course, is how appropriate are the services for the individuals from a cultural and linguistic perspective.
Well, thank you for that, Dr. Laura. Does anyone else have any thoughts on quality of care in mental health, and if you see disparities in your context in the quality of care? With that, then we can continue on to another question. And if any thoughts come to mind, feel free to work them in here. The next question I have is about telehealth. Could you tell us a little bit about how, in your context, how telehealth is influencing your workflow? And also, we spoke earlier about the digital divide and potential equity problems with lack of access to technology. But do you see any positive role for technology in the future and any potential for telehealth to do anything to address some of these issues of access and quality that we've been talking about?
I can discuss our experience with that. So early on, we really had to reduce the number of people who were coming into the clinic and maintain physical distancing and all of that. So we switched to about 50% telehealth visits and 50% in person. We had to create all these scheduling guidelines to so staff would know who's appropriate to be seen in which venue. And we also, so our telehealth could be either phone visits or video visits. And we've had a really tough time with the uptake on the video visits. And it's from, I think Dr. Kuo mentioned it earlier about the, just the technological challenges for our patients. Often, poor internet access and probably some of it's on our end too, not a very easy system to get into. So I would say we're probably doing about 80 to 90% telephone visits at this point in time. And this is going to be a problem because the payers are talking about not paying for telephone visits, just paying for video visits. And certainly in our community, that's going to be a real issue. And many of us feel like there's no going back. Like we're not going to be able to go back to the full in-person model because there were a lot of advantages. Of course, in Los Angeles, you're talking about transportation, parking. At our clinic, unfortunately, there's still wait times before seeing the provider. They could spend, a half day taking care of their medical issues, whereas now, we call them, they're at home. It's pretty efficient. We can order things as needed. So it's, in a lot of situations, it works really nicely. But in order to continue doing that, the payers are going to have to be willing to pay for that. And I'm guessing they must think that there is abuse going on, or, our costs aren't the same, and so they shouldn't pay for that sort of thing. But hopefully there'll be enough advocacy. Certainly in our patient population, we need to be able to have the ability to provide healthcare through telephones until the technology is much more, patient-centered and easy for the consumer.
Great. And thank you. Thank you for sharing that example of some potential for telehealth to actually help patients with some equity issues. That's really interesting to hear about. Would anyone else want to comment on the issue of telehealth, how it's influenced your work, and potential positive roles for telehealth in the future? Yeah, Dr. Casillas?
Similar. I think that for us within pediatric and adolescent healthcare, telehealth has really added on an additional level of flexibility to allow kids to still go to school and get their doctor visits in, because we see the same thing where families may have to before travel by train or bus or car, and it was like a full day. In LA, everything is with traffic. And so now when we do telehealth, we do have had good experience with the video visits, but we've invested a lot of time on the of having enough support for the families. Like if they're not logging on, we have to have one of our administrative assistants call them and kind of talk them through on how to get the code and how to get on the Zoom, and it gets easier. I think there's the learning curve that we've talked about, but then once they do it and feel comfortable, they've stayed engaged for us with multiple visits, but you do need that support staff to try to help them through it. And then, secondly, like I said, kids are now all at home, some are going into the hybrid model, but being able to be at home, do their schoolwork, and then when we need to see them, to look at them, talk with them, go through additional questions that we need from the patient and not from the parent. That gives us additional flexibility. And then for some patients that have to travel very far for specialty care, we serve, even though we're in Los Angeles, we serve a very large rural community in the Bakersfield community, because they don't have specialty pediatric care for certain diagnoses. And so for certain visits, it's been a big advantage for the family not having to travel over 2 hours through the Grapevine with traffic, losing a day of work, to be able to actually get some of their visits in for telehealth. And then similarly, we can order labs in their community so they don't have to spend the whole day at the hospital or near clinic to get those labs done. So there have been definitely some advantages to be able to have flexibility in the schedule for kids and their parents, with both distance as well as schooling. And then families are able to ask, well, I get off work at 3:00. That's when my shift ends. Can I get like a 4:00 appointment? And we can actually meet it, because there's not, they'll be home and then not have that travel time or parking time. So there's definitely, we've seen some advantages, but there are those families, similar to what other people have said. It's, I'm not really sure, but it might be different for our area. But in Long Beach, I know when the kids went out of school, they were offering like free internet service and everything. So it seemed to expand more access for families to have that option to do on the computer. And what's interesting for us, the kids are the ones that are often helping navigate the Zoom calls for their parents. And they're like, okay, can I, go back now to whatever I'm doing? So, but having that support services to help the families be able to get through it and try to decrease the inequities that we might see.
Great. Thank you so much. And again, really helpful to think about how this can help some populations, maybe not everyone, but certainly it seems like something that we should keep around in some capacity going forward. Hearing from both of your experiences there with using telehealth and seeing it be successful. We are close to the end of our time together, so I'm going to read just one more question from the audience to wrap us up today. So last year, the Department of Healthcare Services in California offered a behavioral health incentive that offered funding to support health system infrastructure projects. From your vantage point, what type of resources and support could the state or managed care organizations offer to support and improve behavioral health services and also to promote equity in mental health? Dr. Kuo, I don't know if maybe you have thoughts on that one from DPH vantage point about maybe ways that the state could support efforts around mental health and equity.
Yeah, I think integration of some of the services. I think in general, in spite of incentive programs like this, sometimes what happens is that in order to really optimally care for somebody with mental health issues or behavioral health issues, it's behavioral health services. Usually you need behavioral health services plus probably substance abuse treatment, plus a lot of some of these other community resources that actually gets at other things like housing insecurity and food insecurity. So I think maybe one of the things where the state and others could do a little bit more is to try to, over time, build out an infrastructure like this. I do know that some places, for example, like the Wellness Center at LAC, USC Medical Center, they're starting to try to play around with this, where they have a wellness center that literally has more than 20 co-located organization, but it has a variety of these resources that kind of interact with each other. They have everything from legal aid to food pantries to the behavioral health services and addiction services. And one other thing that they're trying to do is they're anchoring it with a health navigator program run by community health workers that tries to help clients actually navigate some of these services so that it's a little more seamless. So that would be my quick take on this.
I think we really need to invest in our workforce, and we need to bring in people of color who are going to be doing my work, primary care, and move into behavioral health. And because I really think that's more important than ever. People need to see themselves in those roles, and patients. I think Dr. Laura mentioned this earlier. It's all about trust, and I think that would go a long ways. I think we definitely have a workforce issue, and we need to diversify that. So unfortunately, a lot of these funds often go to hardware and, special one-off programs, but I think we really need to start at the educational level.
Yeah, absolutely. That's an excellent point, Dr. Lamp, and I agree completely that the infrastructure we need in mental health may not be buildings or technology, but people who can really do this work, because that's often what it takes to recover from mental illness and to have that support. So thank you. We are just about at the end of our time. So with that, let me turn things back over to Dheeraj to wrap us up for today.
Thank you. Thank you, Dr. Lamb, Dr. Kuo, Dr. Casillas, Dr. Laura, and Dr. Choi for this great panel. I would also like to thank all of our attendees for the engaging questions. I just want to give a reminder that at 3:30 p.m. Pacific Standard Time, we have the keynote fireside chat with John Gao, CEO of Alignment Healthcare, and Anderson's own Dean Bernardo. And you can join this session through the schedule link on our conference website. Thank you.